we did a large study of circulating tumor cells in metastatic castrate-sensitive prostate cancer. So in this disease setting, basically a disease where men with metastatic disease are first being treated with hormonal therapy, the standard of care right now is a combination of hormones with chemo or with other androgen receptor targeting agents like abiraterone or enzalutamide, but we have very little in the way of biomarkers to guide our knowledge of who will respond to these treatments and for how long they would respond. So basically, the purpose of the study was to develop such a biomarker based on circulating tumor cells. CTC analysis has been done using the FDA-cleared cell search platform in a more advanced disease state in castrate-resistant prostate cancer after men have progressed on hormonal therapies. But very little has been done in this first-line metastatic castrate-sensitive prostate cancer. And so our hypothesis, what we asked in the study, is whether the CTCs on cell search could be used as a biomarker to tell us who will respond and for how long. So the study was conducted in the context of a large phase 3 prospective randomized clinical trial, SWOG S1216. It's a study run by the NCI, Southwest Oncology Cooperative Group. The PI on the clinical trial component is Dr. Neeraj Agarwal at the University of Utah. And what we did in this study is we looked at the CTCs at baseline for these men, 1,200 men, who were randomized to start treatment with androgen deprivation therapy, hormonal therapy, with either bicalutamide or orteronel, which is a CYP17 inhibitor, similar in class to abiraterone. And the readouts or the endpoints that we looked at in the data that is now being presented is PSA response at 7 months, meaning how long, after 7 months of therapy, how much of the PSA drop. And we want to look at whether it dropped below 0.2 or between 0.2 and 4 or above 4, which are categories of PSA response that have been previously shown to be an intermediate biomarker for overall survival. So we looked at how well the PSA dropped. The other thing we looked at was the 2-year progression-free survival. In other words, who had progressed on the hormonal therapy and who had not by 2 years. Findings were actually quite dramatic. We found that there was a significant difference in response and in progression between men who had CTCs and men who did not have detectable CTCs at baseline when they started on study. As one example that we discuss in our results, taking 2 men, if a man had 5 or more CTCs at the start of the study versus had 0, no CTCs at the start of the study, the man who had no CTCs had a more than 6-fold odds ratio of having this complete PSA response to hormonal therapy by 7 months relative to the man who had 5 or more CTCs. And conversely, that man who had 5 or more CTCs at the start of the study had a nearly 4-fold odds ratio of progressing by 2 years on the study with hormonal therapy relative to the man who had no CTCs at baseline. And we actually found these types of relationships to hold across the board. We looked at a variety of cutoff points. For example, men who had less than 5 versus greater than 5 CTCs, which is kind of the traditional cell search cutoff that has been used in more advanced disease. We looked at men who had any CTCs detectable versus 0 CTCs. And in all cases, there was a very significant difference in their response to treatment and in their progression, whether they had CTCs or not. In our study, CTC counts at baseline were indeed very much prognostic of PSA response and progression to 2 years in men first going on therapy for metastatic castrate-sensitive prostate cancer. This, to our knowledge, is the largest prospective trial looking at CTCs in this setting. So we're very enthusiastic about these results. We think they could definitely lead us to some important next steps. For one thing, even where we are right now, one might consider clinical scenarios where, for example, a man comes into the clinic and perhaps is an older or more frail gentleman, but has no CTCs. And so in a gentleman like that, we might feel comfortable treating him with more traditional or more conservative hormonal therapies, knowing that he should have a pretty good favorable response to these treatments, versus another gentleman who might walk in and have many CTCs where the indication would be that his disease may be a little bit more aggressive, may not respond as well to just hormonal therapies, and we might lean more towards more aggressive combination therapies or even clinical trials as they become available. So basically helping us to identify which men are likely to have a good response and a protracted response versus men who are less likely to have that kind of favorable response. That's kind of where the data are now. In addition, as the final trial results mature in the coming year, we'll also have final overall survival data. We'll also unblind the trial completely. And so we'll be able to do an analysis of whether CTCs are actually associated not only with overall how the patient does, but also how the patients do on each of the two treatment arms. And so the idea there is that potentially CTCs might be able to help us choose between specific different treatments so that in future trials we can build on that and say, let's see if having many versus few CTCs can help guide us to choose between hormonal therapy and chemo, or hormonal therapy and abiraterone or enzalutamide, because these are the choices we need to make in the clinic today, and this is where we need the biomarkers to help guide our decisions.